بسم الله الرحمن الرحيم. نبتدي البرزنتيشن بتاعنا يا جماعة اللي احنا بنسميه انجوي اوفثالمولوجي. دايما مفيش أي تعارض ما بين إن الواحد يتعلم ويفهم ويجيب الهايست ماركس وإن هو في نفس الوقت يستمتع بالساينس. النهارده البرزنتيشن بتاعنا انتراكتيف ايليد كويز. دايما احنا التيتشنج بتاعنا بنحاول إن هو يبقى بنظام العصف الذهني أو البرين ستورمنج بحيث إن الداتا تبقى واضحة وكلير في أذهانكم جميعا إن شاء الله. أول حالة عندنا ده الاكسترنال appearance بتاعها زي ما انتم شايفين الدائرة الحمراء بتشاور على ليجن في الابر ايلت. الكويز ماشي كالآتي: the most ideal intervention in this 67 years old man is levator palpebral superiorus resection, sling operation, fasanella servat procedure, levator palpebral superiorus resection advancement, or none of the above. طبعا الإجابة مفيش أي حاجة من الحاجات ديت. المشكلة هنا مش في عضلات عشان أعمل ليفيتور ريسكشن أو ليفيتور ريسكشن أدفانسمنت أو فاسانيلا سيرفات بروسيجر. القصة كلها هنا إن وزن الأبر أيليد زايد بالماس اللي موجودة، فده an example of mechanical ptosis، وفي الحالة دي treatment is treatment of the cause. الحالة التانية نبتدي أهو في الفيديو دوت. ده فيديو مصور عندنا هنا في الزقازيق. ركزوا على الحاجة اللي بتمشي على اللاشز. هنا بيسأل على كويز على الحالة ديت: ايه اللي غلط في الحالة ديت؟ Ofloxacin eye drops are indicated, yellow oxide of mercury is indicated, diluted acetic acid is indicated, cutting the lashes is required, commoner in low socioeconomic standard. نشغل فيديو تاني. هتلاحظوا ان في هنا حاجة بتتحرك على اللاشز، ده البارازايت اللي هو اللايس، فده اكزامبل للبارازيتك proliferatis. اليلو اوكسايد اوف ميركوري طبعا ده هو ده اللي بيقتل البرازايت. دايليوتد اسيتيك اسيد بيستخدم عشان لوسن السيمنت سبستانس اللي ماسكه البرازايت والنتس للاشز. قطع الرموش او قص الرموش مطلوب، وغالبا بيبقى في اللو سوشيو ايكونوميك ستاندرد. الاوفلوكساسين اي دروبز ملهاش اي رول هنا لان ده انتي بيوتيك ملوش رول في حاله بارازيتك، وبالتالي الكوريكت انسر هتبقى في الحاله دي ايه؟ الحاله الثالثه which is false as concerns this 2 years old boy. Ideal time for intervention is 6 years old. Permanent visual sequelae may occur. Musculoskeletal problems may be encountered. Immediate intervention is required. Congenital in origin. ايه اللي يلفت نظرنا في الصورة دي؟ ده صورة external photograph جايبة الوش كله لطفل عنده سنتين. اللي يلفت نظرنا ان في طبعا bilateral severe preferatosis، المارج فليكس ديستانس قليله قوي، وفي نفس الوقت لو تاخدوا بالكم ان الطفل واخد كومبنساتوري هيد بوستشر ومطوح راسه ورا، فده اكزامبل لحاله بايلاترال سيفير كونجينيتال توزس. السيفير كونجينيتال توزس التدخل از ايرلي از بوسيبل، اول ما تشخصوا بتعالجوا على طول خوفا من المشاكل والمضاعفات اللي بتحصل. اهم مشكلتين عندنا الستيمولس ديبريفيشن امبليوبيا نتيجه الحرمان من اللايت، وفي نفس الوقت إن الطفل ده ممكن يحصل له مشاكل في الرقبة ومشاكل في العضلات الرقبة وفي الفقرات زي تورتيكولوس، ممكن يحصل له مشاكل في الفقرات نتيجة البوزيشن اللي هو واخده، وده طبعا حاجة congenital. ماشي. نتدخل عند سن 5 أو 6 سنين امتى؟ لما يبقى mild أو moderate doses. severe doses as early as possible. ده اكزامبل للتورتيكولوس اللي بيحصل في بعض الأطفال اللي زي كده. ده منظر نفس الطفل لما تاخدوا بالكم. الطفل قبل العملية كان عامل ازاي، واخد بوستر ازاي، بعد العملية وبعد سكسسفول سيرجري والجفن اترفع خد بوزيشن طبيعي جدا ورقبته اتفردت وبقى كويس جدا. عندنا في حاجة اسمها الامبليوبيا. الامبليوبيا دي ده عبارة عن يونيلاترال احيانا بايلاترال. decrease in the best corrected visual acuity نتيجة vision deprivation and or abnormal binocular interaction for which there is no identifiable pathology of the eye or visual pathway. الستيبل deprivation اللي احنا بنتكلم عنها دي عبارة عن امبليوبيا أو lazy eye ناتجة من الconditions wherein one eye is totally excluded from seeing early in life زي اللي بيحصل في congenital or traumatic cataract الكومبليت ptosis زي الحالات بتاعتنا دهية. ليه احنا بنحاول ان احنا نأجل التدخل لحد 5 أو 6 سنين؟ يعني لو احنا اتدخلنا بدري مشكلتنا في ايه؟ ان احنا شغلنا في حالات الكونجنتال توزس على عضلات بنقص عضلات وحاجات زي كده زي الليفيتور او غيرها وبالتالي انا عشان اشتغل لازم احدد الباور بتاعت الليفيتور كويس. عشان احدد الباور بتاع الليفيتور بعمل التكنيك اللي انتوا شايفينه ده ان انا بضغط جامد على منطقه الايبراوز عشان ناليفاي الاكشن بتاع الفرونتاليس عشان يبقى الاكشن اللي طالع هو الاكشن بتاع الليفيتور فقط. التكنيك ده تكنيك الى حد ما بينفول وانفيزيف صعب جدا ان استخدمه في طفل صغير وبالتالي بحاول اجله لما الطفل يكبر ويبقى كوبرتيف انف ان انا اقدر اعمل مع هذا التكنيك عشان اقدر اعمل بروبر اسسمنت للاكشن بتاع الليفيتور وبالتالي احدد اشتغل عليها قد ايه. السبب الثاني اللي بيخليني برضو اجله لحد مثلا 5 او قبل 6 سنين قبل ما يخش المدرسه خوفا من التنمر اللي ممكن يحصل لهذا الطفل لما يخش المدرسه. وبالتالي الاجابه هتبقى إيه؟ الحاله الرابعه عندنا which is false as concerns this 36 years old man is mostly a unilateral phenomenon, may be detected neonatally during suckling, anomalous faulty innervation and because leave the patient if not complaining, acquired in origin. In this man we can notice he has right ptosis that is relieved on opening the mouth. This is called jaw winking phenomena. Actually may be detected neonatally during suckling. It is a congenital condition, not an acquired, and if the patient is not complaining, leave him alone. Faulty innervation between الoculomotor nerve اللي بيغذي الليفيتور وبين المانديبولار nerve اللي بيغذي المسلز of mastication. ودي congenital origin مش acquired. كلمة winking دي معناها ايه لما نشوفها في اللغة close and open one eye quickly تبقى بالشكل زي الايه تقريبا زي الشكل اللي انتم شايفينه بتاع مستر بينز ده. وده شكل الجو وينكينج as detected during suckling. وبالتالي الإجابة الخاطئة في الحالة ديت بتبقى إيه؟ الحالة الخامسة معانا a 55 years old worker in the intensive Ramadan city on a windy rainy day in his work he came complaining of watering of the eye. This was his external appearance. This is an external photograph of this patient. You can notice severe right lower eyelid paralytic ectropion. He has a facial palsy as evidenced by flattening of the nasolabial fold and deviation of the angle of the mouth to the left side. Pupillary reaction was unremarkable. Intraocular pressure within the normal range. Fundus examination was unremarkable. The diagnosis, as I mentioned, is right lower eyelid paralytic ectropion with lack of thalamus. Cause of watering is loss of tear drainage by capillarity across the sharp posterior border of the lid margin. Due to the presence of ectropion, there is overflow of tears directly onto the cheek. The management on the ophthalmic side, I should cover the globe with antibiotic ointment by night, artificial tears by day, I may tap the eyelids by night to minimize exposure. In severe cases or irreversible cases, I may produce tersophy to minimize the size of the palpebral fissure. The neurologist may give nerve tonics, may give strides, physiotherapy, all are beneficial. The most serious complication on the ophthalmic side is exposure keratopathy. Exposure keratopathy usually affects the lower third of the cornea due to Pills phenomena. Normally, when the person closes his eyes, the eye rotates upwards. The most exposed part in such condition is the lower third. As an example of exposure keratopathy due to left paralytic ectropion. Another example, a 43-year-old man presented with throbbing pain and lid swelling, which is false. The commonest organism is Staph aureus. Immediate incision and evacuation is the rule. The case lacks cardinal signs of acute inflammation. Initial conservative measures are to be taken, P and C. This is an example of Stye, which is an acute suppurative inflammation of the Zeiss gland. This is a typical presentation. The cardinal manifestations of acute inflammation are evident. Usually, we resort to conservative measures by hot fermentations and antibiotics. We're afraid of immediate incision and evacuation for fear of spreading infection to the cavernous sinus through the pterygoid plexus. The correct answer is E. A 34-year-old lady presented with a painless lead mass of 6 months duration, which is false. The lesion lies in the dorsal plate. Biopsy is usually unneeded. Could affect visual acuity. Represents a granulomatous specific inflammation. The mass may get acute infection. It's an example of a Chalazion, which is a very common lid swelling. Actually, the lesion lies in the dorsal plate inside the meibomian glands. Biopsy is usually unneeded except if recurrent in the same place. Could affect visual acuity due to pressure on the cornea and producing astigmatism. It may get acutely infected and give hordeolum internum. It represents a granulomatous non-specific inflammation. As concerns this forceps and this procedure, which is untrue, minimizes lid bleeding, does not protect the lid margin, facilitates lid eversion, a vertical incision through the conjunctival side is the rule. The treated pathology may occur in other meibomian glands. This 44-year-old man had a previous penetrating facial trauma, which is untrue. Corneal protection by ointments is a must. Plastic surgery is indicated. He has no lagophthalmos. Possible corneal complications usually occur in the lower third. Conjunctival xerosis may occur. Actually, this is an example of cicatricial lower eyelid entropion with lagophthalmos. Corneal protection by ointments is mandatory. Plastic surgery is indicated to relieve the lagophthalmos and the ectropion. The answer is C. This 35-year-old worker had a previous sodium hydroxide accidental eye contamination, which is false. Amniotic or mucous membrane grafting is required. Corticosteroid ointments are prophylactic after such a trauma. Visual acuity may worsen if the lesion extended superiorly, may have diplopia on down gaze, may have diplopia on up gaze. This is an example of symplepharon complicating a chemical trauma. Symplepharon means adhesions between the lid and the glue. In such cases, usually we give corticosteroid ointments to minimize adhesions between the lid and the glue. Amniotic or mucous membrane grafting may be required to smoothen the ocular surface and minimize adhesions. If the lesion extended superiorly, the cornea will be affected, and the corneal scarring and opacity will affect the visual acuity. On looking downwards, motility is unaffected. On looking upwards, the motility will be restricted. In such cases, the image falls on non-corresponding retinal points, and the binocular diplopia will occur. Corresponding retinal elements are those elements of the two retinae, the stimulation of which in binocular vision gives rise to localization in one and the same visual direction. The retinal receptors in both eyes that dictate a common visual direction under binocular conditions are called corresponding retinal points. Retinal elements of the two eyes that share a common subjective visual direction are called corresponding retinal points. For example, the fovea of the two eyes, temporal retinal points of one eye, and the nasal retinal points of the fellow eye, and vice versa. This 76 years old lady presented with intense ocular irritation, which is false. Cicatricial, senile, or spastic factors may explain the situation. Orbicularis oculi paralysis may be the underlying element. Corneal complications are of paramount significance. Surgical intervention is advised. Ocular pain and photophobia are expected. We are dealing with a case of lower eyelid entropion. Both cicatricial, senile, or spastic elements may be the cause. Corneal complications are very important and the cause of symptoms. Surgical intervention is advised. Ocular pain and photophobia are typical due to secondary traumatic corneal ulceration. On the other hand, orbicularis oculi paralysis would produce ectropion rather than entropion. This 37 years old farmer presented with intolerance blight, ocular irritation, which is false. The pathology is mainly in the dorsal conjunctiva. Trachoma is the commonest cause in Egypt. Corneal irritation is the cause of symptoms. Medical measures are curative. Lash epilation is a temporary solution. We are dealing with a case of upper eyelid tracheasis. All are true except D. This 8 months boy presented with skin discoloration increasing on straining. His father refused any intervention, which is false. Margin reflects distance, may be negative. Stimulus deprivation and amblyopia is a major concern. Radiological studies to exclude orbital extension are indicated. Medical measures may be useful. The upper lid mass is rare. This is an example of big capillary hemangioma of the upper eyelid, which is a very common lesion in such age, in the eyelids or in the periorbital area or in the orbit. Actually, due to the big weight of this mass, this baby has a big mechanical ptosis, and margin reflex distance may be negative. The major concern is stimulus deprivation and amblyopia due to the derivation of this baby from light during this sensitive period of visual maturation. Radiological studies to exclude orbital extension are indicated. Medical measures may be useful. The answer is E. It is very common, not rare. The margin reflex distance is the distance between the upper lid margin and the light reflex in the pupil in the primary position. This test is used to assess the severity of ptosis. This is an example of the change in the size and coloration of the hemangioma on straining. May be treated with beta blockers, corticosteroids, whether orally or by intralesional injection. Surgical excision may be indicated in some cases. Embolization by interventional radiology sometimes can be helpful. This 80-year-old lady presented with this appearance of 5 months duration, which is false. The pathology is paralysis of the orbicularis oculi. Eyelid surgery is indicated. Leg of Salmus is expected. Antibiotic eye ointment is required for corneal protection. If the same lid mass was in the upper eyelid, ptosis will occur. We are dealing with the case of mechanical lower eyelid ectropion. The pathology is increased weight of the lower eyelid, not paralysis of the orbicularis oculi. If the same lid mass was in the upper eyelid, mechanical ptosis would occur. Lag of thalamus is evident. We can see the lower eye fornix. Antibiotic eye ointment is required for corneal protection. This 22-year-old man had a painless-indurated lower lid swelling for 8 months. Acutely, the swelling increased with pain and tenderness. What's your clinical diagnosis and how to manage? This is a typical example of hordeolum internum or infected Chalazion. Usually, we do conservative measures, hot fomentation, antibiotics, anti-inflammatories to relieve the condition. In many cases, these conservative measures are sufficient to relieve the situation. Surgery is indicated later on. This 45-year-old man with a 4 years history of thyrotoxicosis. He presented with left severe ocular pain and marked drop of vision. We can notice this man has severe bilateral proptosis, chemosis, keratinization of the conjunctiva. On the left side, you notice a big corneal ulcer affecting the visual axis, stained with fluorescein sodium. This is an example of exposure keratitis due to lag of thalamus caused by marked proptosis of thyrotoxicosis, which is false. Systemic steroids are absolutely contraindicated. Radiotherapy may be required. Eyelid surgery may be needed. Orbital decompression may be the last resort. To understand this question, in addition to the treatment of the corneal ulcer, the problem here is the exposure. The exposure is caused by this marked proptosis. Systemic steroids are usually needed to treat the proptosis. Radiotherapy may be required in many cases. Eyelid surgery, like torsorrhaphy in some cases. Orbital decompression may be the last resort to relieve the proptosis. Which is false concerning this boy. His problem is only cosmetic. As for lead ectropion, as lagophthalmos, the main pathology lies in the tursal conjunctiva. A and D is an example of the skin manifestations of scleroderma. The skin is ironed out. Marked stretching of the skin produces bilateral 4-lid ectropion with the ophthalmos. The problem is in the skin, not the dorsal conjunctiva. This is my phone number. This is page for students on the Facebook. This is the YouTube channel. Don't forget to subscribe, enable notification, share, and comment. Thank you and have a nice day.